Thank you, Dr. Ayloo, and thank you for coming. I would like to say that it's an honor to be here, to be invited, and I would like to say thanks to you, Subhashini, specifically for putting together a great panel, and also for being the person who has always innovative ideas in technology, and for giving me the easy task of defending ERCP before laparoscopic cholecystectomy. We don't have any disclosure. Both Dr. Ayloo and we have experience in ERCP, so even if we are surgeons, we can actually understand a little bit the complexity, the challenges, and the indications for performing ERCP, and what are the difficulties and what we should avoid in terms of, sending patients to other individuals who are taking care of these complex patients. So I will give you the scenario of an imaginary patient that you would like to discuss with the audience and see what you would do and why you would prefer doing laparoscopic cholecystectomy first.
So when I was putting speakers for this topic, I invited a couple of speakers to talk who wrote papers on this, but they were not enthusiastic to go against the popular practice right now, which is ERCP and then followed by surgery. So I took up this topic to debate that because there is good evidence towards surgery, I think. So for a minute, I want you to put yourself in the shoes of the patient. Don't think about yourself as with any titles, and imagine yourself being sick with cholecystitis and choledocholithiasis. You had to cancel all your cases, right? And then arrange for childcare. If people who have children or taking care of elderly have a caretaker, and you're waiting around in the emergency room. So what would you like to have done for yourself? The first option is immediately have your bile duct obstruction removed and the root cause to be addressed in one procedure so that you can get back to your routine, get back your life, or have two procedures, which is pre-ERCP, wait few days because, to get a lap chole immediately after ERCP. Again, I'm telling, don't put yourself as a physician, but as a patient. It's challenging, but it will involve two different anesthesia. Or have two procedures where you get your lap chole done, and while you're recovering in a double bed patient room, wait for your ERCP, again, two anesthesia. Better yet, have your ERCP, spend a couple of days in hospital, get discharged, and come back for an elective gallbladder surgery. Or wait around to get your lap chole done and an intraoperative ERCP while the surgical team and the GI team is trying to coordinate their schedules so that they can do it intraoperatively. And then the OR team is trying to figure out how to bring all this GI equipment into your operating room. Which one would you like to go for? So the debate is...
So, of course, the debate is which procedure should you actually, or which strategy you should basically choose. So the question that we are discussing right now is relevant, and I think it is. And it depends on the relevance of the question is the prevalence of the disease and how often we are encountering the condition that Dr. Ayloo has explained. And I would like to ask you if you can raise your hand to tell me, in your experience, who would choose ERCP first? Please raise your hand if you do ERCP first in your practice. 50, probably. Some people don't really know, or they haven't made that decision. And how many people will go ahead with laparoscopic cholecystectomy and common bile duct exploration laparoscopically? So it's a big number. And who is a surgeon in the audience? And everyone is a surgeon? Or who is a surgeon? Can you please raise your hand? Okay. Okay, so everyone is very familiar with the surgical procedure and the case that we discussed. And if there is a dominant established practice, which seems to be a little 50-50, and should we change the current clinical practice? So, of course, you know, every one of us, we have preferences and we work in different environments, and there are different kind of, you know, flow of patients that comes to your attention depending on where they present and who is going to referring the patients to you. In my opinion, to understand a little bit of a debate, you have to go a little bit back in history and have a little bit of a visual background on what happened to the surgical history of the procedure. So if you look at the first cholecystectomy was performed in 1882 by a German surgeon. 7 years later, there was the first description of common bile duct exploration by Dr. Courvoisier. 79 years later, there was the first description of ERCP that at that time by Dr. McCune, who was not really the one who developed and perfected the ERCP, but was the first one to describe that the biliary cannulation was feasible using an endoscopic technique. And then 31 years later, in 1999, there was the first multicentric randomized controlled trials comparing ERCP first, followed by laparoscopic cholecystectomy versus laparoscopic cholecystectomy and laparoscopic bile duct stone extraction. We are 141 years later, and we are still considering this a very meaningful debate because definitely there is no clear strategies that provides better outcomes, and there is a little bit of evidence in both sides that we will discuss with you. Prevalence of gallstones. Gallstones definitely is a very common condition. Everyone agrees that it's common in general surgery practice. About a fourth of women in North America have stones after the age of 50, and about 15% of men have stones that sometimes are asymptomatic. But there are some specific groups which are at much higher risk of developing gallstones, especially North American Indians. And common bile duct stones affect about 15 to 20% of individuals with gallstones. And some of these stones pass naturally, but most of them, they become symptomatic and present to our attention. If we look at the trends or the prevalence of the disease, there has not been significant changes over time. This is a very interesting study published in 2016. As you can see, in 2000, there were 26,000 common bile duct stone diagnosed in the United States. It went up to 27,000 in 2013. It's estimated that using these data in 2030, there will be about 30,000 common bile duct stones diagnosed in the United States. So what is the definition of the disease? It's very simple. So the disease is the condition of stones that most of the times originates in the gallbladder. And then depending on the size, they travel down through the cystic duct and then they end in the common bile duct. And when they are in the common bile duct, they can cause different symptoms, biliary colics. Sometimes they get infected, causing cholangitis. Sometimes they develop pancreatitis due to the outflow of the pancreatic duct. The solution is very simple, so it's not really a difficult condition to conceptualize. It's a removal of the source of the gallstones, so cholecystectomy is usually recommended, and then removal of the stones in the common bile duct. Now, there are two main strategies for this condition. It's to do an ERCP before laparoscopic cholecystectomy, or laparoscopic cholecystectomy, common bile duct stone extraction, intraoperative cholangiogram. And there are other two additional strategies, which is the intraoperative ERCP. So you do a laparoscopic cholecystectomy, you do intraoperative cholangiogram, you find a stone, and then of course you can ask your team or the endoscopist to come and do an ERCP when the patient is under general anesthesia. And the last one is laparoscopic cholecystectomy, intraoperative cholangiogram. You show a stone and then you refer the patient to the ERCP after the operation. These number 3 and number 4 strategies are relatively uncommon, so I will not go into the details about the evidence about those two. So the two strategies have in common, of course, laparoscopic cholecystectomy. And the difference between the two is that if you do an ERCP prior to laparoscopic cholecystectomy, usually the patient has to undergo two different procedures, usually performed by two different teams. The laparoscopic cholecystectomy with common bile duct exploration can be done in two ways, usually transcystic if it's a small stone and if it can be done technically, and the common bile duct exploration, which is usually used for stones which are bigger than 8 millimeters or stones that are impacted that require a little bit a bigger approach for the extraction. So I would like to discuss with you the advantages of ERCP first. So the first is that if you do an ERCP before your laparoscopic cholecystectomy, technically or ideally you reduce the inflammatory response that is following by the stone that is impacted in the biliary duct, and that might facilitate your laparoscopic cholecystectomy. There is also theoretically a reduction in surgical time as you have only to perform the excision of the gallbladder. It gives you flexibility because, of course, you have a little bit of ability to select the patients and perform the laparoscopic cholecystectomy in a more elective environment. And then if you know that the stone has not been able to be extracted by the endoscopist, then you can actually plan your laparoscopic cholecystectomy asking for extra support, extra time, or extra instrumentation, the C-arm, and so on. So it allows you to plan your surgical procedure in a better way. If you look at the technical profile of ERCP, so usually it's done as an outpatient. It can be done under sedation. So when I was doing ERCP, most of the patients were undergoing sedation with fentanyl and Versed. If the procedure is done in an uncomplicated stones, usually it's not very difficult. Once you have the bile duct cannulated, you do the sphincterotomy and you extract stones. Most of the times I would say that it's take about between 10 minutes to 30 minutes. Of course, there is the waking up and sedation, and that may take a little bit longer. Success rate, if you are in a place where they do ERCP at high volume, is usually between 95 to 100%. The difficult part of the ERCP is to justify the pancreatitis and bleeding risk. Pancreatitis, it's a severe pancreatitis, so the ones that is really requiring hospitalization and patients staying in a hospital longer, it's less than 3%. And the risk of bleeding, serious bleeding requiring blood transfusions, it's relatively rare. It's less than 0.5%. The cost of the procedure, it depends where you practice. In Canada, is estimated to be between 2,000 to 5,000 Canadian dollars. It depends on what data you're reading. And then in the United States, it's more expensive. It goes from 6,000 to 12,000, $11,000 with the most recent data from MD Save. And of course, I will now pass it on. So saying that it's a procedure that can be done safely and relatively with modest cost, I will pass it on to Dr. Ayloo to see why she would like to do the bile duct exploration.
Despite the evidence that you showed. So for me, the argument is very simple. Patient is sick with cholecystitis and common bile duct stone. So what do? Sickness is treated by relieving that bile duct obstruction and removing the root cause. In one setup, one anesthesia, by the same surgical team. Now, each individual component out of these three, when done otherwise, carries a different complications. We know when surgical teams and GI teams change, there's different things happen. Anesthesia, subjecting patient twice to anesthesia has complications from it, and two different setups will have different other complexities. So if we address it in one setup, patient is on the way to recovery and back to their normal life. So it's a very efficient way to approach this disease. What do I mean by this? Well, the studies have shown that single stage translates to shorter hospital stay, lower cost, higher rate of stone clearance, and lower rate of stone recurrence. Now, let me pause there for a second because we get so desensitized when we say length of stay is lower, cost is lower. But what does it really translate to? Well, it's a quicker resolution to the patient problem. Go back to that scenario that I gave you. If you don't have a surgeon title, right, and you're in that emergency room, you want that problem to be dealt efficiently so that you can get back to your life. And not everybody is a surgeon. There's different professions. A construction worker cannot be sitting in the emergency room thinking that he or she is going to get days off. So they need to get back to work so that they can pay the bills. And so that means less disruption to their personal life and fewer side effects, like I mentioned before. So for you as a surgeon, it would mean a patient that is treated effectively and successfully and lessening the workload. What do I mean by lessening the workload? Well, if this patient is inpatient, you have to coordinate getting the GI team to come and do ERCPs. If you are sending the patient home or discharging and having them come back to electively, you have to have your office staff track down that person and make sure that they come back so that to avoid any kind of drop-off there. So this is the contention between us, okay? So my debater says that ERCP decompression of the bile duct immediately relieves the symptoms, right? Drainage of infected bile and resolution of inflammatory changes. Well, I'm going to say these objectives can be accomplished by surgery as well. So when you say that there is a reduction of operative time and technically there is a flexibility of doing this electively, well, if we address the problem the first time correctly and efficiently, we don't really need to look at bullet point 4 and 5, right? Those becomes irrelevant. So, and the other advantages that has been mentioned is that if there is limited access to the operating room or there's no skill set for stone extraction and lack of equipment, I say, well, I can turn that around and say in some centers, to find an advanced endoscopist and a GI suite is also a problem. So the decision has to be made by being familiar with what resources are available to you and what support system is available to you. So I want to put out a rebuttal because there was a mention that, elective doing pre-ERCP allows a feasibility for an elective lap chole. Well, I'm going to bring your attention to this study, which has been performed in UK over 6 years. What they did was they looked into their case series of about 200 patients between 2015 and 2020. And what they did was patients who came in, they either they had ERCP done and at the same setting do a lap chole, or they discharge the patient and bring them back for an elective lap chole. And in their experience, when they looked at the operative time, length of stay, and stone clearance, and the necessity for post-op ERCP and reoperations, there was no significant difference. So one has to explain to me why we need to bring these patients back to for an elective laparoscopic cholecystectomy and not addressing the problem in the index admission itself. So the conclusion here is, from this study, that common bile duct exploration can be successfully done at the index admission as long as it's done by a well-trained advanced laparoscopic surgeon. I heard that the ERCP complications are pancreatitis and bleeding, right? Sure, those are the most common ones, but let's try to remember some of the other ones. Duodenal perforations, how many of you manage this? There we go. And how about impacted retrievable baskets, dislodgement of catheters? Oh, wait, the forgotten ones. How many of you found those on the x-rays that we do, incidentally find those forgotten catheters? And the routine stent placement, which means usually these people just don't have their stone removed. They sweep with the balloon, they put a stent in, and then they bring them back again electively, and then sweep again the duct, and then remove the stent. So it's not just one ERCP we are talking about. Most often it is 2 ERCPs or even more, depending on the complexity. And yes, we have done these procedures with fentanyl and Versed, but somehow majority of these procedures are done under general anesthesia. Why? Because there are cases of airway loss and patient death. So that means you need an anesthesiologist. So now you're pulling your resources from an anesthesiologist who is supposed to be in the operating room and helping you do your cases into the endoscopy room. And let's not forget, the discomfort that the patient experiences with the ERCPs, and quite frankly, depending on which day I'm calling my endoscopist, if it's a weekend and the patient has a Roux-en-Y, they're usually lost, and they don't have an incentive to come and do an ERCP at that time. So I just wanted to give the technical profile just to compare against the ERCP that we looked at in the previous slides. Well, even the single stage can be performed outpatient and inpatient, because now 75% of the time, transcystic is becoming very common. And in my own series, I'm not going to put it out as a big series, but in my own experience, I have done common bile duct exploration, minimal invasive, and feel quite comfortable even sending the patient after 23 hours observation, because depending on the complexity and what went on intraoperatively. So there is a possibility for that, and I'm thinking that needle will move towards that profile. In most hospitals, there is feasibility to do lab chole and also bile duct exploration, with the caveat that you do need somebody with a clinical or technical expertise rather. Yes, we do these under general anesthesia, and most series have given an operative time between 2 to 3 hours, just as what ERCP has shown. The important thing is there is a higher stone clearance with ERCP, and the mortality and procedural related pancreatitis and bleeding are relatively lower compared to the ERCP. But I will admit that the bile leak risk is higher with bile duct exploration. That is the only thing that I can see that dings against this, my support for this single stage. Let's look at the hospital cost. If you're looking at laparoscopic bile duct exploration, and these are the studies, by the way, you can go and reference it, it's about, $6,000. Well, if you're using the robot or if you're doing an open, yeah, that price goes up from anywhere from $9,000 to $12,000. But if you're doing a straightforward lab chole and an exploration, this is what has been mentioned in the literature. So that against the ERCP.
Yeah, thank you, Dr. Ayloo. So we always, look at single center or multiple center retrospective studies, and we can find everything that you want to find to support your theory. But if you look at the randomized control trials, I went back in 1999. It was the first randomized trial done in Scotland by Kuskieri and colleague, and it's very important to go back into looking at the data at that time. Not many difference in the report of current data. So if you look at what they did was dividing in two groups, 150 patients, lab chole, ERCP prior to lab chole. The ability to follow the protocol was 90% versus laparoscopic cholecystectomy and intraoperative cholangiogram and common bile duct exploration. The endpoints were a hospital stay, success rate, conversion rate, morbidity, and mortality. So what they found, and it's very important to understand, so normal ERCP was about 20% of the population. Successful ERCP was 95%. Endoscopic stone extraction, 84% of the cases. And then they proceeded to laparoscopic cholecystectomy in 85% of the patients. And then they did the laparoscopic common bile duct exploration was necessary in 12%. And conversion to open common bile duct exploration was only 3%. Let's see what happened to the group B. The group B was intraoperative cholangiogram successful in almost every patient, 90% of the cases. Normal intraoperative cholangiogram was in 15%. Bile duct stones were found in 82%. Transcystic exploration in 50% of the cases, as well as common bile duct exploration in the other half. Transcystic exploration failure, 19%, common bile duct exploration failure, 15%, conversion to open common bile duct exploration was 6%, so double. And of course, these are very old data that might be much better now with the new technology, but still you can see that there is a difference in between the two groups. So when they did the side-to-side comparison between the two strategies in effectiveness, 95% versus 96%, there was no significant difference between the two. And the mortality was 1.5% for ERCP, and then I will explain to you the difference in mortality from 1.5 to 0.7%. And of course, in the ERCP group, there were more individuals with cholangitis and with severe pancreatitis. The main difference, as you can see, the hospital stay was 9 days versus 6 days, and this seems to be typical findings among all the studies that report the two groups comparing each. So they concluded that there is equivalency in success rate between the two strategies. In their conclusion, they say that for fit patient, single-stage laparoscopic treatment was their recommended strategies, and for individuals with the compromised comorbidities or sick, they prefer to do the 2 stages laparoscopic cholecystectomy after ERCP. So the current status currently, of course, you will have to explain why we should move away from that randomized trial, and I will invite you to the podium.
Thank you. That was an important paper to start us off with, which is about quarter century ago. So let's see what it is right now. So this paper is a multi-institutional paper looking at bile duct exploration in management of choledocholithiasis, and it's a big study of 4,000 patients, and it's also a multinational study from 17 centers. And when they looked at it, the most common cause for, most common indication for bile duct exploration was jaundice. I understand in experienced hands, the ERCP could be 99% success, but if you look at all 17 centers retrospectively over a span of 5 years, right, in 4,000 people, bile duct exploration was required in 15% of failures of ERCP. Most likely that's the reality, not 1% failure rate. Yeah, in expert hands, yes, individual series maybe, but when you look at overall how it is doing, I think this is the realistic number. A most common approach is transcystic. I put down 63% here, but I've been going around listening to other sessions, and it's up to 75 with using other methods such as lithotripsy, the success rate for transcystic. But there is also a failure rate with bile duct exploration, which is 4%, much better, 3 times lower than failed ERCP. And the median OR time and morbidity are not significantly higher, but the bile leak is definitely higher, 4.5%. Again, if you have a bile leak, and that increases the length of stay. I'm going to rush through a little bit because we are running short on our time. So in this paper, the conclusion is that bile duct exploration is safe and effective and can be performed by experienced hands. So what is the problem? When I'm saying that this is better in every other way except for bile leak to address the problem, why are we still 80% of us who are surgeons trained surgically still doing endoscopically? Well, this is the same study that took one step further and surveyed these surgeons, the experiences that they gained on. And if you notice that more than 80% of the surgeons said that they have very poor training in bile duct exploration. So unfortunately, surgical residencies, at the level of surgical residency, there is a gap at educator level. And on the other hand, with the GI fellowships, they've been trained to say that standard of care is to do ERCP first before you do LC. So even before you get a surgical consult, they already have a GI consult, and maybe an ERCP has been already scheduled.
All right, so you bring up very important points. So in terms of, when I ask if you do ERCP first, 50-50 was the distribution. But if you look around what is known right now, that 93% of the general surgeons in the community in North America, they would recommend to go through an ERCP first, followed by laparoscopic cholecystectomy. What is the main reason for this choice? Well, if you ask them, 42% of the individuals, they don't have the equipment or they haven't done laparoscopic common bile duct exploration. There are some limitations in terms of time and lack of staff in the operating room. More importantly, to see what is the trend in over time. So if you look in 1998, 52% of people were undergoing laparoscopic cholecystectomy after ERCP. In 2013, 85% of individuals were treated with ERCP prior to the laparoscopic cholecystectomy. More importantly, the common bile duct exploration was 5% laparoscopically, went down to 1.5%. And 96% of the surgeons who were interviewed, so 46% of this group of 700 surgeons who responded to the questionnaire say that they have never done a laparoscopic common bile duct exploration or a common bile duct exploration. So they didn't really have the skills to do the laparoscopic common bile duct exploration. So the more important is that, more studies have been published, over the most recent time. And what they show basically that the two strategies are equivalent in terms of ductal clearance, mortality, and morbidity. What is very common is the difference in hospital stay, which is in average 1 day less for individuals who do laparoscopic cholecystectomy. With a common bile duct exploration. Now, there is a new, very nice meta-analysis that have included the most recent randomized trial and 13 observational studies. And from these meta-analyses, you can see that laparoscopic common bile duct exploration wins over ERCP first in terms of ductal clearance, perioperative complication, conversion rate, residual stones, recurrent stones, mortality, operative time, that in my opinion seems to be counterintuitive, but the majority of the advantages seems to be cost effective because it reduces the hospital stay. The issues for a surgeon is that, as Dr. Ayloo said, the common bile duct exploration comes with an increased risk of biliary leak, and therefore, as a surgeon, I think this is very important to keep in mind. And then, of course, there is the rebuttal that Dr. Ayloo will now discuss.
I'm going to rush through the next few slides because I don't want to impinge on the other speakers' time. There's a systematic review here. Essentially, they looked at open cholecystectomy, bile duct exploration, laparoscopic cholecystectomy, laparoscopic bile duct exploration, and then pre and post ERCP two-stage procedure. The Cochrane review came up with they looked at different categories. Essentially, they didn't see any difference. So their conclusion was that we needed more randomized trials. Well, let's look at some other meta-analysis. This is about 9 years old meta-analysis, which included 15 randomized control studies. What they found was that bleeding and pancreatitis was essentially higher in the endoscopic group, whereas the bile leak and greater percentage of stone retraction, lower hospital cost, and mean operative time and length of stay were better in the surgical group, and there was no difference in the retained stones or total complication. Essentially, they said surgical approach is better. This is, again, another meta-analysis from 8 years ago, 8 randomized control studies, essentially recommending that we proceed with the surgical approach rather than this two-stage approach. But I want to bring you to up-to-date, which is just came out in this year, and it is in this society's journal, and the editor is sitting, who is my co-moderator, Dr. Seppa here. So this must be a good study. It's 25 randomized control trials with more than 3,000 patients who looked at different categories, which is the surgical group here, and then pre-ERCP, intra-ERCP, and post-ERCPs. They had good number of patients. There is a disclosure. There has been a little bit of heterogeneity in the study, but looking at that, again, reinforcing what we know, that a little bit slightly increase in bile leak and conversion portion with the surgical group, but bleeding and total cost and pancreatitis were better in the surgical group. But if you can, you can get a setup where you can do a gallbladder surgery and intraoperative ERCP, it has much better technical success and reduce morbidity. So in conclusions,
You can
yeah,
go through the conclusion.
no, here.
All right, so I will take the honor to go through the conclusion because we think that we have reached the consensus. You have a common bile duct stones. I think the first important question is surgical skills. Are there? If you have surgical skills and you have an operative room available, yes, go ahead, do the surgical laparoscopic cholecystectomy and common bile duct exploration. I think that if you don't have the surgical skills or you have not done it, I will recommend to go through ERCP. If you don't have an operative room available, or if you have equipment problems, go in ERCP. And of course, if the surgical equipment and nursing staff is not adequate in your institution, do an ERCP. So, Dr. Ayloo, if I count is 1, 2, and 3, the conclusion is that laparoscopic cholecystectomy, in my opinion, scores 3 points, and you just have a score of 1.
Not so fast, Michele. Yeah, well, let's see. If you don't have advanced GI skill endoscopist, you have a failed ERCP because you couldn't cannulate the ampulla, or you have a retained stone, or an impacted stone that's not coming out with the endoscopy, or you have recurrence of stones, right? Your first approach is gone. And then just like OR operating room availability, if you don't have a GI suite, your second approach is gone. And if you don't have, just like surgical equipment and nursing staff, you don't have an endoscopy equipment and nursing skills, nursing staff that's specialized in endoscopy, the third approach is gone. And so you're left with lap chole and bile duct exploration. Thank you. There are 2 clinical trials that are going on. I'm listed. This presentation will be up on the website. But I want to introduce my co-moderator, Dr. Seppa, who is professor at Indiana University in the Division of Surgical Oncology and also Transplantation. Dr. Seppa will introduce the next 2 speakers.